Our final speaker is Dr. Kevin Donovan, who is the director of the Georgetown Center for Clinical Bioethics, succeeding his mentor, Dr. Edmund Pellegrino, in 2012. In addition to his responsibilities as director, he is a professor at Georgetown University Medical School in the Department of Pediatrics. Co-directs medical students' education and ethics, bioethics education for resident physicians, and directs the ethics consultation service for MedStar, Georgetown University Hospital, where he still participates in medical consultation for his specialty. He is also a senior clinical scholar at the Kennedy Institute of Ethics. Dr. Donovan was the founding director of the Oklahoma Bioethics Center and has 3 decades of experience in clinical bioethics and clinical medicine, being recognized as one of America's best doctors. He has been the medical ethics consultant to the Roman Catholic Diocese of Tulsa, chair of the bioethics section of the American Academy of Pediatrics and its Committee on Bioethics, as well as his state medical association, the Oklahoma Organ Sharing Network, the Oklahoma Genetics Advisory Council, and was founding member of the first VP of the Oklahoma Association for Healthcare Ethics. Today, Dr. Donovan will be speaking on brain death, a potentially mortal wound to transplantation. Please join me in welcoming Dr. Donovan.
I'm not sure it's really an accident that this topic was saved for last. I think half the audience is brain dead already. Before I begin, I really do want to thank Ryan. I want to thank Carter. I like being here very much. I've liked coming to these conferences. This is how I got my start in bioethics originally, when I was a mere practicing physician. And this is where I met my mentor, Edmund Pellegrino, and then arranged to go study with him on sabbatical. And I suppose it's fair to say that these conferences, for me as for others, have been life-changing. Thank you, David. So let's talk about fun stuff now, okay? First off, the obligatory, right? What does this slide say? As we said before, it means you don't get any money for doing bioethics. Virtue is its own reward. Now we're going to talk about brain death in the terms of a potentially mortal wound to transplantation. I think one of the interesting things about this is how effective the President's Council was that considered this issue, that considered the other issues that we've heard about this weekend, and has several of our previous members sitting at the table with us now. And so we're going to take another look at this because I think, to my own thinking, perhaps their good findings weren't looked at closely enough or still aren't. The diagnosis of death, okay, what are the implications? The natural end of the trajectory of human life lies in death. I try and convince all of our budding medical students this, that no matter how good they are, if they follow their patients long enough, they will experience a 100% mortality rate among their patients. Also, people have been dying for a very, very long time. So what's new? What are we talking about now? Well, as you know, fear of death has been universal, which is why we don't always want to talk about it. Fear of burial before death has been present throughout the ages, sometimes, as we'll see, triggering some almost comical responses. But people now have come to fear that they will have their organs harvested before they are dead. And if you wanted to see a whole lot of headlines about that, you know, brain dead patient wakes up, you know, here's the doctor's talking about donating his organs. Perhaps you don't read the paper as you go through the checkout line at the grocery store, but those headlines are not uncommon. All right. In fact, the fear has been so universal and so long-standing, gimmicks like this were actually marketed, and people would have little bells, little whistles. Some people insist on being buried with their cell phones, but I think that's just because they weren't done texting. So the criteria for the declaration of death, and I'm trying to make a point here in terms of terminology. We haven't redefined death. And you'll hear us say that. I'm sure I've used the phrase myself, new definition of death, but it's not. Okay? Death is still the irreversible cessation of life. And I suppose life is the absence of death. But always in olden times, meaning up until about 1960s, the heart would stop, breathing would stop in any particular order, and a person was recognized as being dead. Now we can have brain death preceding those other two phenomena. Why do we need a criteria for brain death? Quite frankly, we know why. It's so we can remove the organs while they're still on the ventilator. Those perfused organs do us a lot of good for our patients, and I have been happy that my patients have gotten transplants. One of the things to remember when we talk about brain death, and taking patients off the ventilator and such is, you don't have to diagnose brain death in order to take them off the ventilator. And many people act like, well, of course we can't until that happens. Of course not. You can take them off the ventilator, for the usually good ethical reasons, and they will die. And if you're not trying to harvest their organs, there's no harm done. So it's interesting to see that the discussion on this goes back as far as 1957, when the World Congress of Anesthesiologists queried Pope Pius XII. Why anesthesiologists? Because then, as in some cases now, they were the ones who had skill with the ventilators, and they were the first intensive care doctors. And they would have people on the ventilator with, quote, hopeless cases. They wanted to know, do they have to continue them on the ventilator? And they were told, no, only ordinary means are morally required. Can a ventilator be withdrawn, even if death is likely to follow? And the answer was, yes, of course, respiratory support is extraordinary. It can be withdrawn with family permission. This was the Pope back in 1957. Okay, can death occur after severe CNS trauma while still on a ventilator, or do you have to have complete arrest of the circulation? And this Pope was clever enough to say, wait a minute, that's not a moral question. That's a scientific question. That's not ethics. And we're still working on that one, aren't we? So what has happened since then? Well, in 1968, the Harvard Ad Hoc Committee met and published their lovely article in JAMA. One of the things, if you've read it, not everybody read it when it first came out, but if you did go back and read it, you'll notice that part of their justification for publishing this in the first place was so these organs would be usable for transplantation. The President's Commission then took this concept and ran with it, and in 1981 and 1983 expanded on both these discussions in terms of defining death and deciding to forego life-sustaining treatment. Now, already by this time, European surgeons had been removing organs from persons in what they called coma dépassé. But Thomas Starzl, pioneer of transplantation in this country, said at the time, I doubt our transplant team would accept a person as dead as long as there was a heartbeat. You'll be happy to know that the transplant team got over it. Okay, a redefinition of death with an avowed purpose of transplantation could create doubts in the minds of the layman. He might fear a transition from a definition to euthanasia. So the terms that have been used, you already have seen, we've been using different terms for this. Whole brain death is what we are talking about when we're talking about brain death, cortical and brain stem, which is probably the same as what they were talking about with coma dépassé, which is now passé. Irreversible coma, cerebral or neocortical death, and PVS are not currently accepted as any kind of definition of death, although there are some who are going to argue for them. The President's Commission justified their interpretation this way. They said that death is a process of respiratory and circulatory failure, and these are inevitable following brainstem failure or otherwise could lead to it. So, heart, lungs, brain are lined up in any order you want. Failure of one inevitably leads to the failure of all three. However, if you're on a ventilator, it interrupts that natural progression, okay? It interrupts the timing of it. Their argument was it will not, cannot prevent it. And so they fully expected anybody on a ventilator who was diagnosed as brain dead to have cardiac arrest, because of course they're going to continue breathing as long as the ventilator's going, within hours to perhaps days of the time that brain death was diagnosed. So they said these are the same phenomenon recognized by different clinical signs. They were making the accurate point that we're not redefining death, even though it was called that, but we are redefining the criteria by which we recognize death. And therefore, we say it's a process in which all functions of the entire brain are irreversibly lost, or irreversible asystole occurs, without which the entire body ceases to function. This is obviously for patients still on the ventilator. Now, these got reflected, as you know, in the law. And the law followed the ethics. And so the Uniform Determination of Death Act says basically the same thing. And in most states, they say that the determination of death must be made in accordance with accepted medical standards. Many of the laws included this original language, provided, however, all reasonable attempts to restore spontaneous circulatory or respiratory function shall be made prior to such declaration. Now, that has some implications for other ways of obtaining organs, including donation after cardiac death, so we'll have to revisit that. But the entire thought here was, because the brain, controls the integration of the function of the body, in the absence of the brain, the body is no longer an integrated functioning entity and must therefore disintegrate in those functions inevitably. And this has been then endorsed by both hospital policy and the criteria set by the American Academy of Neurology. The interesting thing about hospital policy, depending on where you work, you may find that the criteria don't match the other hospital in which you work, because I have seen this, and I'm sure some of you have as well. So the diagnostic criteria for brain death, I am not going to go through step by step. We do this with the medical students, but I let the neurologists do it. The important parts of it, of course, are that there are 3 cardinal findings. And you will notice they are clinical findings. The diagnosis of brain death is a clinical diagnosis. There are supportive tests for that sometimes are required depending on where you are or not. But in a patient who is comatose and you have good understanding of why they're comatose, you've eliminated the other possibilities, they must be unresponsive in their coma, they must have absent brainstem reflexes, and they must be apneic. Hard to judge when they're on the ventilator, but obviously not impossible. You take them off and see what happens. The confirmatory laboratory tests are optional, despite what they put in those same tabloids at the newsstand. Okay. Now, we have seen some challenges to the diagnosis of brain death, and I think there's some reasons for that. The application of the criteria varies widely, even when the criteria remain the same, from hospital to hospital, state to state, or country to country. And it's not just their application. The actual criteria as listed will vary. And in studies that have been done by the neurologists, they've seen, I think it's as many as, 27% or something like that, of places that have these criteria don't even require an apnea test as part of the determination of death, which is interesting, that being one of the 3-fold criteria that indicate the clinical presence of brain death. It was 27. I actually didn't look, okay? I hadn't peeked, but it was 27. Glad to know. I'm awake if no one else. Brain dead patients, however, if they, quote, wake up, shouldn't be dead. Nobody has ever been shown to meet the criteria for brain death, carefully applied, and then wake up, with the possible exception of Lazarus, but nobody actually did the apnea test. Lazarus, it's a story I'll tell you later. But some patients like this Zach Dunlap did. He said he heard the doctors talking about harvesting his organs. Clearly this was not a brain-dead patient. J.H. McMath, we will talk about. Much confusion exists both in the medical and lay literature about brain dead versus brain damage. And I would put it to you that these people who recover consciousness after a diagnosis of brain death never had an accurate diagnosis. Can't prove it, but I'm really certain it's true. Okay? Why do we have this kind of public confusion? Brain dead people are said to be not legally dead, until their heart stops. They are thought they can hear. People say, shh, shh. Nurses will tell the family, they might be hearing you. This may be even after the neurologist has left the room and diagnosed them brain dead. Some people think they don't need ventilatory support, and so they will confuse PVS patients who are off the ventilator with a brain dead patient. You know, people think they die when their heart stops, even after they've been diagnosed as brain dead. And they think they're as good as dead. And some philosophers use that argument. All of these, by the way, as you know, I hope, are false conclusions. The problem with it is we're responsible for some of those. What actually happens is that we talk wrong. We speak about our patients wrong. We go and say, you know, I read an article once, which I thought was really fascinating, about some people who went to the IRB, got permission, they wanted to study some of the physiology of brain dead patients while they were still on the ventilator. And they had about, I think, 4 or 5 patients. But they couldn't really complete the entire study because, as they wrote in the article, they had to stop when the patients died, meaning the heart arrested. You know, they were doing a brain death study, but they had to stop because the patients died. Okay. Now, currently, there are some legitimate challenges. Does brain death really lead to irreversible disintegration of bodily function? And how can brain dead patients continue to function, to grow, to develop for months on a ventilator if the brain cardiorespiratory failure concept is to be accepted as an inevitable continuum? Now, to their eternal credit, the President's Council addressed this issue and tried to redefine the criteria. But I put it to you that most people who are asked to explain why brain death is death still go back to the same explanation. With other determinations of death, if we're not going to use brain death, the thing we have to also consider is, what does this do to the dead donor rule? I'm sure you're all familiar with the idea of the dead donor rule. We do not take organs, unpaired organs, from patients, you know, unless they're dead. The problem is that there are people who say, well, actually, forget about the criteria for diagnosing death. What we really want to do is just forget that ridiculous dead donor rule. It's getting in the way. Others say, absolutely not. You know, it's not only the moral, ethical thing to do, it's also the practical thing to do. If we don't do a dead donor rule anymore, we will lose all of our patients and no one will ever want to donate. Where on the continuum, and I think it is a continuum, can we define death with moral certainty? And do our actions cause death when we are manipulating our patients for purposes of organ transplant? And are we intentionally causing death, or is it inadvertent? And another question would be, you know, when can organs be removed without causing harm or death? And those two aren't identical. So one answer, as you know, has been DCD, donation after originally called cardiac, now circulatory death. You know, I think they wanted to change the terminology when they realized it's awkward calling it cardiac death and then explanting the heart into someone else and have it beat. And then trying to explain, yeah, it was cardiac death, it's just the heart wasn't dead. So it's now called circulatory death, non-heart beating donations. Donors with severe neurologic injury but are not diagnosable as brain dead can have life support withdrawn under protocols, wait for the heartbeat to stop for a specified period of time, and we'll get into that. Once it has stopped, you observe them for a specified period of time, and then you can remove any organs you want. This too has ethical controversies. What if the heart doesn't stop soon after withdrawal of life support? Typically, these patients are brought down to the surgical suite, okay? And they try and maintain the separation between the treating physicians and the transplant physicians, the harvesting physicians, but they take them off the vent and they wait for the heart to stop. They wait. They wait. And sometimes it doesn't stop. And so they have to build into the criteria how long are they going to wait, you know, before this is no longer going to be an effective procedure. When the heart does stop, this is where it gets even trickier. How long do you have to wait to consider asystole irreversible? And while you're waiting, is it okay to optimize the value of these transplantable organs by trying to prevent them from getting clots, trying to prevent them from getting other anoxic damage or something. So can we put in large bore catheters and can we infuse them with anticoagulants? These are patients who are not yet dead, but are dying. Okay. So how long do we wait? Various experts have given us different answers. Initially, it was said you will not get auto-resuscitation of a heartbeat, spontaneous recurrence of a heartbeat after 10 minutes. Well, then the Institute of Medicine said in 1997, a 5-minute waiting period between cardiac death and organ removal should be sufficient. There are no reports of auto-resuscitation beyond that time. Now, for reasons that were never quite clear to me, and someone will perhaps be able to explain it in our discussion periods, why the Society for Critical Care Medicine said, well, the truth of the matter is, you know, it's good. It's really kind of irreversible after 60 seconds, so there shouldn't be any auto-resuscitation after 2 minutes. I don't think this was based on new information, but tell me if it was. And said, okay, we're down to 2 minutes now. And in Denver, they used a 75-second waiting period after discussing it with their ethics committee. So the question becomes, is the patient dead from loss of circulatory function? Because asystole is either permanent or irreversible, not identical. Permanent meaning the patient will not, the heartbeat will not return, and it's not going to because we're not going to do anything to resuscitate it. These protocols do include placing a do not attempt resuscitation order. Or is it irreversible? Patient cannot resume cardiac function while that heart is still within this dying body. And those are actually two different sets of circumstances. So that's the situation that we are faced with currently. And we are still doing transplants, and patients are still benefiting from them. And many people in this room have their organ donor cards in their wallets. Where should we go forward with this? Is death by cardiopulmonary criteria the only reliable and verifiable definition? Because, in fact, this was one of the options that the President's Council suggested. Is death by whole brain death criteria or cardiopulmonary criteria acceptable? That's what we have now. Or the alternative, which I'm not discussing for purposes of time, and also because I don't agree with it, that's my prerogative, is higher brain death, cerebral or neocortical or PBS, marking the end of someone's meaningful human life, and therefore that should be the new standard, and we can have all of those organs we want. And the advantage of that is you don't even have to take them off the ventilator because they're breathing without one anyway. But they're perfusing that heart and the other organs themselves, but you know, they're just being selfish because they have no particular use for it and we can use it more. Not how it's usually expressed, however. All right. Given that, I think that there are a couple of cases to discuss. It would be worthwhile seeing how these criteria apply or don't apply. And if everybody's still awake and willing, let's get back here and talk about it after 10 for the return.
Where are you at? 45 minutes. So
Upstairs.
go back here, order up.
All right. Go out there and have some fun with this. Thank you.